Thank you. We're now recording. And just to remind everyone that it is available on the SERSH website afterwards, the recording, within a day or two. So just a couple of little, before we get started, you're all very used to this by now, but just a few little housekeeping things. Please mute your microphone when you're not speaking, because there's always a lot of background in all of the areas that we're transmitting from. And utilize the chat function for additional questions, because it can be frustrating sometimes when you're dying to ask something and you seem to have been ignored. It's not deliberate on our part, it's just that we can't see all of the tiles all the time. So do use the chat function, and we are recorded. So tonight's agenda, we're going to make this a bit of a working party tonight, and really hope to get some outcomes where we hear from you what you would like us to deliver over the next year. We're very excited, Kath and I, to be able to say that we're going to be on the road again this year, and have already planned 2 or 3 outings in the next month or so. So we want to do more, and we want to make them for the communities that we visit. First of all, however, Carolyn Mockabell from 1-800-MY-OPTIONS is going to give what is now the opening segment of every meeting that we have, Carolyn, an update on how things are traveling, and as always, the data that we get from these talks from you and from 1-800 in general are so helpful. So over to Carolyn to begin.
Thanks so much, Patty, and thanks everyone for having me. It's great to see such a good turnout to this meeting again. As always, a great diversity of people from across the state and Australia. So 1-800-MY-OPTIONS, we've been pretty busy, and one thing that I can reflect on really strongly is that January was, we've used the word unprecedented a bit too much in the last couple of years, but January was off the charts for us. So we know that we're getting more calls now that we're open 9 to 5 instead of the previous 10 to 4, but we had 25% increase on what our expected increase was for January. So every week we had over 150 calls, just about, people looking for abortion contraception across the state. It was a bit of a perfect storm, I guess, January, of situations where services were closed over the holiday period. We had a couple of times where teams were furloughed in health services because of COVID exposures. A few people became unwell or had injuries that were practitioners, and it really started to show that the system, although it's still strong and full of so many passionate and wonderful people, still has some vulnerabilities, as you all know, particularly in rural areas. But it was really hitting in Melbourne as well, where we were seeing wait times blowing out beyond 3 weeks for some services, which is not something that's happened in the history of 1-800. Things are starting to settle down. Our call numbers are back to somewhat normal, which is around about 100 a week at the moment, and it's what we expected. So we are still seeing pretty standard trends from our callers in terms of what they're seeking. So still somewhere between 70% and 75% of our callers are less than 9 weeks pregnant, which has just been consistent throughout the lifetime of the service. We are still seeing a slightly more people in the second trimester than we saw before COVID. And I think that there's a variety of things that are contributing to that. There are fewer services that can see somebody in the second trimester. We know that people are being bounced around a little bit more because of that, I think. But it's become a bit of a consistent thing since COVID started, that second trimester abortion seekers, it's still really tricky to find services. We're still really consistently also seeing around 15 to 18% of our callers coming from rural areas, which is great. It's slowly creeping up. I think that slowly we are starting to see word of the service get out into rural areas. We also have some really exciting news coming from Women's Health Victoria. So 1-800-MY-OPTIONS is a service of Women's Health Victoria, and Women's Health Victoria hosts the Women's Health Atlas, which is an atlas of data about women's health indicators across disaggregated to female and male rates, looking at over 60 indicators of health from everywhere from experiences of violence to cardiovascular stuff to sexual and reproductive health outcomes. In November, we updated STI stats on the Atlas. So you can see the STI stats for every LGA in Victoria, disaggregated to male and female. We've recently acquired the data for medical termination and also for IUD and Implanon, hormonal IUD and Implanon. We're in the middle of processing that data, and it needs to also be approved by Services Australia, whom we acquired it from. But at some point in the next couple of months, we will have data on the Atlas down to LGA level, looking at the number of patients who have received medical abortion prescription, the number of prescribers in that LGA, as well as the number of pharmacy dispensers. So this is going to be really useful to look at for planning. We've got the data back from 2017 through to 2020. So we'll be able to look at the impacts of services as well as plan and look at where do we need services. We can say from preliminarily looking at the data that the demand for MTOP is pretty consistent across LGAs. There's a pretty standard rate of demand per 1,000 women of reproductive age. But what we know isn't standard is provision. So this data is going to show us exactly which LGAs don't have providers so that we can start working with those LGAs and the LGAs around them to look at provision, as well as which LGAs don't have dispensers of MS2 steps. So it's going to be really useful for planning. It's going to be really important, I know, for 1-800-MY-OPTIONS in working with communities and working with different areas of the state around advocating for more provision. And I will let you all know when we actually have that published, which again will be in the next couple of months. It'll be free to use for everyone. Thank you.
Sorry, could I just ask, free to use for all the public as well?
Yep.
Fantastic.
That's on the Women's Health website.
Yeah, that's fantastic.
I'll pop a link to the Atlas in the chat for this meeting. It's worth looking at as it is right now because it's got information. I think the IUD and Implanon is up to 2018 or so currently in the Atlas. So it's got a lot of indicators that you can use to compare that data with. So it's got things like adolescent birth rates, it's got birth rates for LGAs, it's got a lot of indicators that are really relevant to women's health that are really useful to look at so that we can explore, you know, what are the common things that women are experiencing across and between LGAs.
That's fantastic. And do you have somebody working on that full time?
Yeah, so Women's Health Victoria has somebody who manages that huge amount of data that goes into the Women's Health Atlas. It is so exciting.
Great. Well, do send us the resource. Does anybody have any questions for Carolyn with regard to what she has presented? I was just going to quickly mention a housekeeping thing which I'm noticing is really useful. Is on the chat, people are actually introducing themselves, and now that we've got up above 20 participants, we're never going to go around and saying who are you and where are you from. Some of us know each other quite well, but just even putting in as Elise did, hi everyone, Elise here from Women's Health Loddon Mallee, it's great so that we can be you know, seeing who it is. And when you do ask a question, just remind us again who you are. Okay. Just following on from what you were saying, Carolyn, about 1-800 noticing that slight increase in gestational age through January, we have also really noticed that fairly much through from November of last year, a sustained increase in average gestational age right through the summer period. And we're only just this month looking over the first 2 weeks and reflecting that it might be going down. And our postulate about that was it wasn't necessarily the ups and downs of the pandemic, because we tried very hard to chart our gestational age intake versus whether we were in a surge or not. But it really seemed to be that at the beginning of the pandemic, we had a phenomena of quite a profound surge in later gestational age requests. And then towards the end of 2021, when Omicron struck, another big surge, which was sustained. And last week I was talking to both providers in Brisbane and also in Adelaide, having the same phenomena, but starting in January and now carrying on, which fits with what's been happening in terms of the pandemic. So it's certainly a very well observed phenomena, and something that we've had to plan for and put on extra lists for here at the Women's, because we've ended up on the whole being one of the very few public providers of greater than 14 weeks. So thank you for that. Any other comments or questions? Was that a question?
No,
I'll keep an eye on that. Sorry, it was a sidebar conversation for Kat. Anybody else wanted to ask anything of Carolyn? No, thank you. And welcome. I think Bendigo has just come online, so welcome, Bendigo. So the second part, or the working part of the evening, is really around what challenges and opportunities in abortion and contraception service development, to acknowledge that we now can get out on the road again and come and visit the hubs and come and visit the local community health centres, as we did for the first 2 years of the project. Over the next 2 months, starting in April, we're visiting 2 of the local regional areas, and the kind of things that we're doing is varying from one-on-one IUD training, so train the trainer type session where the GP will bring their patients and I will be there to do a one-on-one session and increase clinical acumen and confidence for the GPs in those areas. Evening information sessions, networking sessions. If we go to a local area where we've already got one networking session set up, where we'll contact the secondary hospital near the hub and try and get everybody who's a provider in the region to come for a networking session around a topic of their choice. So those are the kind of things that we can do. We are working with the marina provider who has they have access now to a pelvic trainer, so we can actually utilize that when we come out, which is another way of learning. It's complementary to actually having patients in the room, and it's probably quite a good entry level simulation to have for doctors and nurses who are considering doing IUD insertion. So we would really like to hear from any of you about what you might like to see and what seems to be the big challenges. Is it still getting GPs and GP trainees to do the early medical abortion training? Is it around LARC insertion? Is it around getting more nursing staff? Let us know what we can help you with. And Louise, I might, because I really, there are no wrong answers. We just really want to have a bit of a brainstorm with you about what would be useful. So Louise, you and Marianne had been talking to us quite a lot about what we might do when we came to Bendigo. So what do you put?
And Karishma's there.
And Karishma's here as well. Yeah,
Is Karishma on?
here she is. She's up the
Oh,
top. Yeah.
yeah.
Karishma, did you want to say something?
Well, the latest issue we've had is a bit of an issue with GPs sending appropriate referrals to us. So we've been having a chat about if in the future we could have some kind of a session with the GPs around in terms of what services we provide, you know, what up to what gestational age they should be sending the referrals to us. I think that's something we need to talk about. I'm not sure if that's something that we could organise, you know, through SERSH as well to help us in educating GPs around us.
Sorry, we were mute. Yeah, you go, Louise, and then I'll reply.
Oh yeah, I just want to add to that, and I know that Tanya Hode's here, Tan, who's the midwife who works at the Choices Clinic at Bendigo Hospital with me as a nurse practitioner there. And we talked a little bit about just still the confusion of GPs in regards to referring women for abortion services and even IUD services. And I've had 2 in the last week where we've had GPs who've referred women for investigations in relation to, you know, PCOS and IUDs. And that when I've spoken to the individual, they've asked to be referred to the gynecologist at the Women's Health Clinic. So they're actually just, for some reason, ticking Bendigo Community Health Services in terms of gynae stuff and thinking that's getting to women's health. But the critical thing in regards to medical abortions, and Jen, I can see you're there and you're from Donald, is that GPs who just don't even have the consideration to look at the gestation and just refer women on who are totally inappropriate for a medical abortion and who are under the impression that they can have that done quite easily, and then being told that no, that they're over the gestation time and then they need to be referred to a hospital. And it's just time consuming for us, really difficult for our GPs who have to ring around and get all the investigations to re-refer on. So we have spoken about what we will do individually as an organisation, but I'm interested to see if Wangaratta or any of the other services that probably have nurse-led services as well are experiencing that. It just appears to be that it's just increased in the last kind of 3 or 4 months, these inappropriate referrals.
I'd love to hear from others, but could I just unpack that a wee bit more with you first? Is your impression that, and I can say this, is this doctor laziness to send it through to somebody, or is it a knowledge gap? What do you think?
So my understanding is that everybody would realise that the health pathways, whether they're Northwest Health Pathways or Murray Pathways, are all there. We update the Murray Health Pathways quite on a regular basis if we've changed something, for example, the anti-D issue and things like that. So they're there on the desktop. I think Karishma and I have actually agreed that it is probably laziness, that they just see a situation, see an issue and refer it on, and actually don't even know the difference for us in Bendigo, whether Bendigo Community Health Services is the Bendigo Hospital. I can't tell whether doctors don't know, like they just don't understand. And I'm very conscious, of the timing that doctors and GPs have for clients in GP land. And I don't know what the quick answer is, but I really think that, one of the frustrating things, if you talk about what we need in hubs, in all the hubs around the state, what we need is our GPs who are trained in extended skills to be able to do those extended skills, so we can actually keep the amount of appointments there for the clients that need it, and not be wasting half an hour doing another doctor's job because that was an inappropriate referral.
And again, the reason I'm drilling down on this is to work out if a response from us and an education evening for GPs in your local area would fix the problem or not. So that's where I'm coming from about working out strategies to try and respond to this. So Kath, you were going to say something, and then we were going to ask Wangaratta, I think, about their experience. What was your comment, Kath? Sorry.
Oh, I was just thinking a few things actually. Like it feels like there needs to be communication from lots of different angles over a long period of time. That, you know, where we've done information sessions, you know, that's relevant for that particular point in time, but it really relies on perhaps the PHN through their health pathways network to keep following up. And, you know, for instance, today, Carolyn and I had a meeting with our GP liaison, and, you know, I've been really keen over a long period of time to keep the 1-800 My Options logo visible through our newsletter, through our hospital newsletter. So that might be an opportunity for you to engage with your communications team in your health service, whether it's a community health centre or the hospital, to get something in the newsletter that goes out to GPs, or get your PHN on board. It's always difficult with sexual and reproductive health because it's on no one's particular agenda, including the PHN. So sometimes it's hard to get traction and visibility within PHNs, but you know, that would be my suggestions.
So meaning, Kath, if we solve the GP's problem of a one phone call fits it all or fixes it all, that they go to the trusted state-funded service that they should know about by now, but they may not all know about by now, for their patient. And then that would mean that your triage function doesn't need to be so lengthy, etc., and you can have your GPs doing their extended and nurses doing their extended skills. So,
yeah, that's right. I'm just noticing Carolyn's got something there too. And the other thing I should mention is that there are some resources on the women's website that focuses on early medical abortion, and this is really written for the GP audience or potential you know, clinician who could be involved in care, to let them know about what early medical abortion is, that, you know, here's the criteria, here's how to get involved if that's what you want. So I'll do the link to that and put it up on the chat. And I'm just noticing.
Can I just say,
sorry, you go.
Louise, yep, so Kerry from Gateway Wangaratta, that we often get referrals really inappropriate, thinking that we're gynaes. And really, it's just a matter of getting back to that woman, to that doctor. But yeah, it is. I think it is laziness overall, that they just sort of think, oh yeah, they'll deal with it. They'll deal with it. We don't have so much of an issue with the timing of the MTOPs, because we do the workup for the stops as well. So we have a little bit more leeway there. So lots of people just refer on, and we can do that. Over that, we use 1-800 My Option. But I think we also regularly have, like, it seems to be sort of okay, and then the referrals and are really, really bad, or the, you know, just all the wrong tests coming in with the women. We regularly then send letters out to all the GP clinics around the place. It doesn't, you know, solve the problem, but it certainly helps. I don't think an education session with GPs would really work, because if you're not passionately interested in that area, they just wouldn't come. They would not attend them. As interested as you are to hear speaking, Paddy, I don't think they come at all.
No, I agree. Yeah. I think you'd be preaching to the converted and telling them that they have to do a good referral. And it's like teaching, you know, the proverbial, which is wrong. Yeah.
What I did find really, really helpful was for a couple of years in a row, I did some booked into the local education session with the registrars, the GP registrars, and I have people, you know, doctors ringing me up saying, oh, look, you know, have I done everything right? And so that's really nice, and that's been really good. But it's going to be continuing the MCCC because everything's changing. But that's been really worthwhile doing that. So
right, I'm writing that down as a suggestion, because getting into the GP's training is something we're really keen to do. There are two hands up. Should we go Romy first, because we haven't heard from Romy, and then back to Karishma?
Sorry, Karishma, I think I definitely bumped the queue. My name's Romy. I am a GP from Gippsland. I was just thinking about your the issues that were mentioned. Is there any like triage process for referrals? Like if there was a, this referral will not be accepted unless it this and this have been completed before, because certainly we often get things sort of referred back, or a letter, sort of electronic letter back that says, please do this before an appointment will be provided. Would just be one way of making sure that someone doesn't actually sort of turn up on your doorstep and then you can't provide for them. But maybe that you've already done that already. Was just I guess a thought, and I think part of the problem, I mean for everyone, but I think part of the problem in general practice at the moment is that time, the time constraints that were always an issue, I think through COVID have just become even more of an issue. People are probably just, are rushing people in and out to sort of get through. So the other thing would be if there was like a online sort of electronic referral where you had, tick boxes of the things that, you had done. So you tick the box for the bloods, you tick the box for the ultrasound. That's a prompt for the GP to remember to print that off. And it means that when they come to you, that they've done those things. It just would be another suggestion. Not sure if either of those would work, but just.
Yeah, those are really good suggestions. And the history of the health pathways originated in Canterbury Health in New Zealand, and we have in Australia done a bit of a copy of that model. The very philosophy of it, Romy, was your patient doesn't get an appointment till you've done the right thing, and you can't press submit until you've done the right thing. But that hasn't translated exactly the same in all healthcare services. And I know in my own service, GPs still send in a sneaky fax. I haven't done the needful, but she's really vulnerable, and so there'll still be ways around that. But those points, and maybe that would help with Louise's issue, if there was some way of, you have to do this before we can accept it. Another thing that quite a few places have used is a fax back. Thank you for your referral. You haven't completed the following, and the fax back, you just might tick the things they didn't complete and you send it to them.
Like Kerry was saying.
Yeah, a bit like Kerry was saying. Yeah. Karishma.
Well, frankly, most of the points have been covered. I was just going to add a bit to Louise. I agree completely that most of the times it's laziness from the other GPs, but sometimes we also feel that there's an element of lack of education from them as well. So being trained through I think we got to know a lot about different things, but never, a service like this was discussed openly. And this is one of it's a very common presentation in GP land where a woman turns up and says it's an unplanned pregnancy. So, and I think it will absolutely make sense if more training is provided to new GPs, registrars, or even IMGs coming from overseas. So if we could have like an area-wide, when you're going or coming over to Bendigo, if there are services, or if we could have those education sessions over a lunchtime or a dinner meeting where we bring the GPs around and just tell them these are the services, this is how we provide them, these are your local providers. It's helpful for the patient itself as well, because we feel that some of the times the time is wasted because the female is being knocked from one service to the other. So they need to be aware where the services are, and it's useful even for the new GPs that come into, rather than they learning from the older one, they better learn it from us.
So I think, am I hearing that you are advocating for a GP education evening, possibly in your area?
Yeah.
Which is a little bit different from what Kerry's impression was. But just a couple of things, Catherine, to everyone. Catherine Falconer, I would like online MTOP training if appropriate. Is there such an educational tool?
Well, that's a hot topic, actually, because we, the Clinical Champion Project, were funded by the health department during COVID, actually, because obviously we didn't go anywhere. And we're in the process of producing an e-module for early medical abortion, and it'll be ready in probably about another month. And the resource will be free. It'll be accessible through the women's website, but it'll actually link to the Women's Health Victoria website. It'll be branded as the women's because it's ours. It's just that women's don't have the capacity to host a module. So that's why we've partnered with Women's Health Victoria, which is a really ideal partnership and collaboration because we work so closely together. And the content of the module, it's designed to be read alongside the clinical practice guideline, and there's other clinical tools in there, but it's also broader than just the clinical pathway. It's got a chapter in there about the broad context for abortion delivery, and a section also in working with women and pregnant people in their decision-making phase. And there's a section also about normal follow-up and a deviation from normal managing complications. So that's a tool that will be available in the next month or so. And just in case medical practitioners and pharmacists in the audience don't know, to become either a prescriber or a supplier of MS2 step for early medical abortion, that's accessible through MS Health. But it's only medical practitioners and pharmacists that can access that training tool. So that's why we thought it was useful.
And even more so than that, it's only medical practitioners who've registered and got their training that can get the patient information booklets and can log on and see where the pharmacists are, which is something we have brought up time and time again, but it isn't going to be improved. So this is kind of our response to that, so that here's a free, easily available, user-friendly system with lots of links, as Kath said, to other things, including the legal situation in Victoria, the legal situation across Australia, and information about domestic violence, for example, screening. So it kind of branches out from there. And I think I'm being very happy with the company that's developing it for us. So we'll be very keen to send that out as a launch for you all.
Yeah. And thanks to the various people around the room who have provided their expertise into the development of the module. And I just, Katie, you okay? I'm just going to go to here to find the link.
Yeah, sure.
So just don't be distracted if you can't see people.
So we're just trying to send you all the link. And look, just back to what Carolyn was saying, that it's very frustrating, Carolyn from 1-800, very frustrating when GPs just get a patient to call 1-800 when the patient was in the room with them and they could have ordered the bloods and the ultrasound, and then the patient has to pay for yet another consultation in order to get those things, and that there's got to be some kind of way around that. And whether it's education or denying access for the GP, making it inconvenient for the GP unless they follow the guidelines. And I do not want to be seen as critical of GPs and saying that they're just lazy. I know how busy they are, and I have this issue in miscarriage management where no matter how many education sessions we do for GPs and say, look, we have an early pregnancy assessment, semi-acute service, don't send your patients to the emergency department after hours. There are no scans available after hours. We will give them an acute appointment. We still are flooded on a weekly basis with patients who are just sent in because even though it's bad behavior, the patients get looked after, and I think that's kind of back to you, Louise. They know it's probably bad behavior, but crossing your fingers behind your back that there'll be a nice person on the end of the phone who does the needful, rings the patient, sorts it out for them, and so there's a limit to how much behavioural change we're going to get out of this, but we can certainly look at those different methodologies. Does anybody else want to, from one of the other centres, who's got their hand up?
I'm just noticing there's lots of people here whose names I don't recognise, and I haven't sort of seen them in the chat. Wondering if you've got any other experience.
How about Elise or Bianca or Amelia? Any local experiences, or Louise Manning or Tan?
That's Tanya.
Oh, Tanya. Yeah, that's Tanya.
Hi, everyone. Yes, again, we have similar experiences with inappropriate referrals and that sort of thing, but I sort of put it down to just our title, Women's Health, thinking as we're Women's Health Clinic at the hospital. But yeah, with Women's Health, we're just, with our Choices Clinic, definitely has its peaks and troughs in the last couple of weeks. It's definitely been a little quieter. We have had a fair few failed to attend, but then I've looked at my schedule for the remaining of the week and people have rebooked. So that's good. We're still utilising our shared care model with the GPs in Castlemaine who are seeing clients in a timely manner, which is awesome, for ultrasound and consult, and just referring to Bendigo Health for their stops and using Bendigo Community Health as required. Just assisting people with future contraception, choice and access. So seeing many clients for contraception advice and assisting with access and referral for LARCs.
So Elise, if I could just feed back that since the Bendigo Community Health's been working so well, and your shared care service has been working so well, and the Bendigo Choices clinic, whatever we service, yeah, with the stop list has been working so well, that the number of later gestational age patients from that area is significantly less than from other places. So, you know, pat on the back, and you're doing, you know, you're getting it right, I think. You know, and when we do get a referral, it's always incredibly appropriate, and it wasn't because someone had dropped the ball. It was because the patient had presented late, it was picked up late for other reasons, or they were there because they presented for an assault at the hospital, for example. You know, so always really appropriate. So even when we come up to Bendigo, it might be really important to celebrate the way you're all working together and increase the network even further, spread it out even wider. And then the learnings we'll get from you will take to the next visit somewhere else, you know? That's kind of the model we're trying to work on, you know?
Yeah, so yeah, at the moment, I don't feel like there is too many challenges. There's always, you know, like everyone else has mentioned, but I feel like otherwise we're assisting these women. It's quite streamlined, and access has been really good. So yeah, everyone, Bendigo, keep up the good work.
I'm just aware of the time, and I did want to ask some specific questions about how we might roll out IUD training. So are there any other comments about the kind of things that we can bring with us when we get on the road? And I've written them all down so far. Anything pressing before we move on to the issue of IUD training? And again, okay, well, we'll move on to that. And again, Louise Holland, can I open with you, just describing what your issue was, what we've chatted about, and what we're going to try and roll out when we come up there next month.
You're on
and
mute,
you're on mute,
Lou.
darling.
Unmute. Okay, that's better. Yes, and we're so excited, and thank you. We're just so grateful to the Champions Project. So we're very fortunate that with the roadshow, that with Paddy coming up, so Karishma, who's here. So what we're looking at is that we've lost one of our GP registrars who in 2021 did IUD insertion training and did quite a lot. Now, I know we do have Louise here as well, who's almost finished her GP registrar and doing IUD insertions. But to just give you a bit of a glimpse of how popular LARCs are becoming, I did 4 pre-Mirena checks today in my clinic. So these are ranging from 22-year-olds to 36-year-olds. Often they're actually referrals from GPs who've heard about us and heard about the IUDs in the at the hub. And so they've come from a referral for an IUD, which is totally fine because often they need quite a lot of information and education discussing the type of IUD that they would prefer, you know, and doing all the consult. So that's just, it's remarkable that's happening. And so with Louise, Dr. Manning doing them, we're kind of down to her hours. And so we're so excited that Karishma is going to do them. So we've got our clinic date set in late April, and we will be booking women in to see Dr. Kerr, and Patty will come and do the clinical assessment and supervision. So Karishma, well, at the end of that, will be trained in IUDs, which will be the plan, and that will certainly allow us then to meet our demand. Our demand is quite high now, to the extent that as a nurse practitioner, I'm incredibly keen to pursue this myself. I know there's nurse practitioners out there working and providing IUD services, and certainly Louise Manning has been very supportive in terms of some of her work once she's completed her training to be supervisor. So I think what we'll find is that, you know, Bendigo will probably once again be able to have an expansive service for IUD insertions. And just to give people a bit of an understanding, I found out the other day that a very senior GP who works in one of our well-known clinics, he does IUDs. He might do. I was actually preceptoring the practice nurse who's just done her screening training, and she said that GP does IUDs, but does probably 1 or 2 a month, and only from his clinic. So, you know, like there's obviously GPs out there that do them that we don't know, and that wouldn't accept referrals from outside their practice. So that's interesting too, in terms of kind of finding out from nurses who does what in private GP land as well. Yeah, so that's what's happening. And then I think Tanya, who's here, we're hoping that the Bendigo Sexual Health Hub team and Bendigo Health Choices team and all the clinicians involved will have a networking opportunity to look at where there's opportunities for expansion of services in regards to abortion services and contraception services, either, you know, a more fluid referral from the hospital. So one of the conversations I've had with the manager was around postnatal women being booked in for IUDs, as opposed to going out after they've had their baby and going to just a random GP for their 6 weeks check with a prescription for the pill or the mini pill because they're breastfeeding or nothing, and not having that closing the loop. So I'm all about closing the loop at the moment. That's the services, yeah.
Yeah, because you're in an ideal position, Lou, on a number of levels, actually. The fact that you're nurse practitioner, but also that you work across the 2 key sites, the health services, the community, the hub and the hospital.
And so that's given, just wanted to make one comment about the IUD model, and then also a comment about what your statement has made me think about that we could do when we come up next month for the networking session. So the first thing that I wanted to just share with you, Karishma, was that we have done a similar session before with a previous GP, and as somebody who trains GPs down in Melbourne, where they have to come to the big hospital, either in the city or they've got to come from suburban Melbourne, or they've got to come from their practice from far away and sit with us for 3 or 4 clinical sessions and learn to insert, that when it's done locally and the patient knows the service and trusts the service, and may even have met the GP before, but has certainly met the nurse before because of this previous pre-workup, Louise, that the insertion rate was 100%. And our insertion rate when we're teaching in our clinic, and the person is coming from a satellite GP clinic, is around about 60%. So it's really good, and really good feedback for the patient, and really promotes, you know, that holistic health center model of care. So it really, you know, was, we thought that maybe 2 sessions wouldn't be enough, Charisma. There were more than enough because we had 100% insertion rate. So just to, and that's all the pre-work. So that model, if that works again, then the next trip and the next one, and the one that the next people are going to invite us to, because we only go where we're invited. We're very polite. We don't force ourselves on anybody, but that we can share that model with you and reassure you that it actually works really well to do it locally. And the GPs are happier doing it locally because they don't have to travel all the way. And we're so damn glad to get out of the hospital that we are really happy to come.
Especially after COVID.
Especially after COVID. And so then the other thought, Louise and teams from Bendigo, is that session that we're proposing for the networking session could be really a very, you know, wide thing about networking and how the hospital could work with the community centre and vice versa, you know, and could the ONG registrars be allowed to rotate? Could they be allowed to teach? Could the GPs be allowed to go to the hospital? All of those sorts of things we could bring up in that networking session.
We really look forward to having you.
Who was that? Oh, yeah. Sorry, I was looking at somebody whose mouth wasn't moving and I couldn't work out who it was that was speaking. Yeah, so we're really looking forward to it, and we get lots of ideas when we leave the hospital. Does anybody else have an experience with IUD training? What worked, what didn't work? We're aware that there are quite a number of ways of doing online theory training, but it's the getting the clinical experience that seems to really make a difference. And we're really interested in exploring this concept of training someone who then becomes a hub specialist in IUD insertion, who then trains the next generation of practitioners.
Can I just,
We've
sorry.
just seen Ian come.
I just want to add something. I really think that, you know, we do have some fantastic GPs out there who are now becoming very experienced in IUD insertions, and it'll be really wonderful. And I don't know how we advocate to the state government, but if those GPs are aligned to a hub, you know, we've got quite a few hubs around the state, and if those GPs get some incentive to be part of that hub as a clinical mentor or whatever, as opposed to just coming in and, you know, working in the hub where they could go and work in private GP practice as well and probably earn more money, but have an incentive to stay within that hub and become one of those mentors and those teachers. Because I think that advocacy to the state government in regards to really establishing a very sound framework in regards to IUD clinical mentoring in the regional areas will only grow and create a sustainable workforce. And I think it has to happen, you know, from maybe the existing hubs that already have a bit of a model. And I'd be very interested talking to like Albury and even Barwon, how they do it, and actually, you know, that proposal to the state government around supporting hubs, but actually cementing another component of what a hub is all about. I think that would be really useful.
Thank you, Louise. And it's almost like we're feeding you the lines, because Kath's got a bit of a news about a model that we're developing.
Yeah, well, it fits in with Sorry. I was going to talk about the policy, but it's more around our funding proposal that we're currently developing up a funding proposal that includes a train the trainer model for IUD. insertion to do exactly what you're talking about, so that the skills are more visible in the local community to support, you know, other providers, other nurse practitioners or other GPs.
And we're really hopeful that we will get this funding, ongoing funding, because it's money well spent for the government if they don't have to keep on funding us to go out again. Like it's, you know, it's the decentralisation writ large for LARC insertion.
Yeah. And I suppose my hesitation before was, it's just, you know, this thought is really supported by the reproductive health policy, the women's health policy that's in draft form with the health department at the moment. So yeah, we're sort of all
and we
working on the same page.
Yeah, we spend a lot of
great.
time informing them and discussing this development with them and looking at the drafts. So it's good to hear you say that, because it reinforces that the hubs are keen. Louise Manning's got her hand.
Hi, thanks. Can you hear me? I'm sitting outside on the balcony in Mildura, supposedly on holiday, but can't seem to never be able to get away from work. Thanks for having me in the meeting this evening. So I work with Karishma and Louise at Bendigo Community Health Service, but I also have a couple of other hats in that I am the chair of the Maternity Services Working Group of the Victorian Rural Doctors Association. And I have been in the process of trying to organise some meetings with you, Patty, outside of this, which we'll get to, I'm sure, at a later date. I just wonder what sort of involvement with VRGP or the Victorian Rural Generalist Program is already in the works, because understanding that most people who are going to undertake LARC insertion or IUD insertion are going to be GP obstetricians, because they'll have insurance and they'll probably have enough workload, and they'll probably be trying to do other minor gynae stuff as well. What sort of links do you already have in that space, and how would you like us to try, like as regional hub people, try to engage these trainees coming through more?
Yeah, look, it'd probably be good to continue the conversation, Louise, because we have some links with the training programs, both probably more so in Gippsland than your side of the state. But yeah, with our road trip, I've actually initiated some contact again with I never can remember what they're called, the MCCC. So yeah, the GP training program on your side of the state, on the Murray to the coast, I think it is.
Yeah, Murray City Country Coast. My only caveat to that being that as of the end of this year, all general practice training is moving back to the colleges. So RACGP and ACRM will be running their own training. So having the centralised Victorian Rural Generalist Program people would be an easy in, but there's small numbers. So I think really the only way that we're going to improve access and I guess skill set for women's health is if the colleges make it a priority and that women's health is seen as an issue. What really gets my goat is that RACGP, which trains most GPs, of which there are tens of thousands of members in the country, have no requirement as women's health make a prerequisite. Whereas ACRM, the rural college, you do have to have done a women's health term, which makes sense because if you're out in the middle of whoop whoop, you've got to be able to catch a baby just in case. But it's just appalling in my mind that RACGP don't value women's health as its own independent area of necessity, and that's why there's so many GPs out there that just go, oh no, too hard, can't be bothered. I don't want to do pap smears even, because why would I need to do that?
So I think that'll be something that, you know, when we do get our meeting, I know we had to cancel before Christmas, I think it was, and in January, that we'll bring this up and do a lot more work with you on that. And we've got some contacts also from the MCC to pursue. Yeah. I'm just aware of the time, and I always promise for the last 5-10 minutes to just go around the regions, and if anyone had anything they wanted to update us on, to provide an update on your current services or current challenges, whether you've gained a practitioner or lost a practitioner, anything you want to share. How are things going in Echuca? How are things going up that way? Mildura, Echuca? Oh, Ian's talking.
Can't
We just
hear
can't
you,
hear
Ian.
you, Ian. Your mouth is moving, but we just can't hear
You're
you.
not on mute. Maybe try your settings.
That's right. I've
Oh,
got to
yeah.
talk
Oh,
to my
good.
wife.
Excellent. Yeah. Hello,
I've got to
Ian.
talk- Yeah, so we established an early pregnancy advisory service up here with a MTOP, but I guess the problem is with GPs and their referrals. Again, you know, women really need to be referred with the appropriate investigations performed. That's something that's fairly new. It's been going now a bit under 12 months.
Mhm.
As far as the LARCs are concerned, one of the problems GPs have, if they're inserting Mirenas, then they become procedural GPs, and so their medical indemnity increases.
Mhm.
So if you have them in hubs, which are basically government run, they should be covered without having to have the extra private insurance.
Yeah, it's a very important point, and some GPs are not prepared to take the risk unless they have got that cover. I understand that.
And the other problem we have up here is we've got a large number of the SIMGs, both as GPs and also consultants, who are a little bit averse to doing medical terminations or any terminations at all. So that becomes a little bit of a problem which we're addressing.
Yeah, but look, you've got just clap, applause all around for Mildura for getting that service up and running. And so
Yeah.
it's been going for about 12 months now, hasn't it?
Yeah, it has, yeah.
With some surgical service as well, isn't it, Ian?
There's a surgical service as well, yeah.
Yeah.
So,
So-
yeah.
And again,
that-
we've noticed a change in the number of patients being referred, you know, urgently because they're
Sure.
over the gestational age,
Yeah,
which
yeah.
really makes a difference.
That's good. Okay, so I'll have to leave you now because I've got another engagement.
Nice to see you and hear you.
Okay.
Bye-bye.
Okay, see you later. Cheers.
Hey, we think you had your hand up, then you put it down. Can you talk?
Yeah, sorry. I was just going to ask, I'm busy trying to look at this document, the women's health, I don't know what you would call it, but the thing you were talking about before. Could you just, excuse my ignorance, but could someone tell me where the hub services are? Please?
Yes,
There
look,
are
we can
eight.
we
There
can
are 8
cite them.
hubs,
Yeah.
and we didn't include them in our e-module, and you really can't get a list of them. Probably 1-800 My Options have got the list, but there's 4 rural and 4 in Melbourne. The ones in Melbourne are at Monash Health, at Peninsula Health, at each Community Health Centre, which is in Ringwood, and Co-Health at Laverton. And then the rural ones are Wodonga, Wangaratta, Gateway Health,
Bendigo?
Bendigo, and Ballarat, and Bairnsdale, and Hyder, all those.
Mm-hmm.
Because they're all nurse-led clinics. They're all in community health. Well, actually, that's not quite true. They're not all in community health, but they are mandated to provide early medical abortion and LARC services, and some are at different stages of development. They're not necessarily providing all of those services.
And the
Yeah.
other thing to let you know, Romy, is that the
Oh, yeah.
department will announce 3 more this year.
Oh, that's exciting.
Yeah.
So watch this
It is,
space.
and we really want to increase the pressure on our support for those services, because as Kath says, some were up and running, some were absolute stars, others have really struggled to retain staff or to differentiate themselves from a gynae clinic in a couple of instances. So there's a real variation in who is really performing to, you know, their potential.
And, you know, like we're talking about with Bendigo Community Health Service, that they can also become like the local clinical champions in their community in terms of you know, being having a service that's really embedded and having experienced practitioners who can support you know, could be or emerging providers in the local community.
So Romy, where are you exactly?
So I live in Druin, but work in Moe, and have definitely I sort of do general practice, but I also do forensic medicine. So do
Yes.
a lot / almost all of the sexual assault exams that happen in mainly in Gippsland, because they come to a central site in Morwell. And I guess increasingly I've also been emailing you, pestering for a meeting, but I haven't got back to you for a while. But I'm sort of keen to I'm about to go on maternity leave and I need a project, and I'm keen to
I think you've got one.
well, you know,
Sorry,
another one.
this, but I think you've got one.
But I'm just really, I just feel that there's a real lack of you know, services for women from a sexual health and reproductive health backing. You know, and I guess from my, you know, general practice I see that, and then from forensic practice I see that, where there's no, you know, there's no drop-in place to send someone. There's no, you know, and particularly looking at Latrobe Valley, you know, it's not an area where people can come and pay money to see the clinics that provide the services are very good clinics, but none of them are free, and none of them are available for 3 weeks for an appointment with a GP that can do any of that stuff that you need. And yeah, I just can't. And I know so many of my, you know, friends and colleagues that do bits and bobs and are really keen to, you know, to be part of something. But I just feel like there needs to be a place where that happens.
Couldn't agree more. Kath has just said we will follow up with some times.
Yes, lovely.
And you know, Gippsland has been one of the places where we have been advocating for just that kind of a centre. So we're still traveling, hopefully. When do you go off on maternity leave?
Not until the middle of April.
Okay, good. Right, we'll be drilling down on that before you go. Okay?
Yes, lovely. Thanks.
That's great.
4 minutes past 7. Anyone else want to tell us anything from their region before we close? And when's our next meeting? We need to announce our next meeting. Anyone else? We're just looking up the absolute date of our next meeting.
Sorry, I haven't got it, but unless
Sarav,
do you know when
Sarav,
it is?
can you just remind us all when the next meeting is? I should have had that at my fingertips.
Anyway,
just looking them up. Yeah, just looking them up.
We'll put it in the notes as well. Anyway.
Anyone else?
Oh, the wait.
I'll just go back to that. So Sarav is going to send that out on the newsletter. Yeah.
Yeah, I can't seem to find it, but it'll be included. Yes.
My apologies for not having that on the tip of my tongue. And so, is there? Can I just see if there's anyone else who wants to say anything before?
21st of June.
21st of June. Thank you, Sarav. 21st of June, another Tuesday night. And we will, by then, we'll have already done 2 trips. So we'll be informed by the 2 trips and we'll share with you.
We'll be on the road to Ballarat.
So if there's anything else anyone wants to say, otherwise, we will, no, I think that's it. Otherwise, we'll close for tonight. And thank you again. Great turnout for our first for the year. Thank you very much, everyone.
Thank you.